Podcast. I'm your host, Dr. Spencer Nadolsky, and with us today, we got one of our all-star clinicians at Sequence, Dr. Chelsea Height. She is a med peds, meaning she's board certified in both internal medicine and pediatrics, and is also an obesity specialist. Today, we're going to be talking about insurance coverage, what everybody hates, the whole insurance process of getting these medications covered. So welcome, Dr. Height.
Thanks for having me.
Yeah, so let's go over the process because you've done this in your own clinic, and obviously we have our whole team here at Sequence that does it for our patients. But let's go over some of these. Let's go over just the basics of coverage for meds in general. If you can go over some of that.
Yeah. So when we look at medicines that we use frequently for obesity and weight, the GLP-1s, obviously, that we use frequently are expensive drugs. And so when we prescribe any medicine, usually what we're trying to prescribe are generic medications. So for general stuff like blood pressure, some diabetes medicines, we try to do drugs that are affordable for patients because obviously that's going to get the drug in the patient's hands and make it much more effective if they're actually able to take it. So when we look at generic drugs, it's usually easy. The drug goes through. We don't hear much back from the patient. That goes through the pharmacy. No big deal. But then when we have to write a branded drug, so a drug that's still under patent, usually the newer medicines, they are pricier. And in the world of GLP-1s, much pricier. And so usually what happens there is insurance companies prefer you to use cheaper options. It costs them less money up front. So they will require what's called a prior authorization. So this is us justifying the medication essentially to your insurance company. Like, this is why the patient needs the medicine and we'd love for you to pay for it. And so when we do that, it requires some work on your physician and the nurse end. And at Sequence, we have a fantastic team that's all they do is they work on that prior authorization. And depending still from that standpoint, after the prior authorization is done, then the insurance company makes the final determination on, yes, we'll pay for this medicine. No, we won't pay for the medicine. And so some of that gets murky on if they decide to or not. And it's not every insurance. It's not Cigna versus Blue Cross versus Humana. It is different among all of the plans and based off of whether or not your employer has elected to cover some drugs. So it gets really confusing at that end of things when you get into the prior auth world. And so thankfully patients aren't responsible for that, but it remains a huge headache for patients because it's a big waiting game. And, where their doctor or clinician is telling them this med would be great for you, like, let's do it. And then they go to pick it up at the pharmacy and it's $1,000. It's frustrating on all ends. And so it's a big barrier to care there because, one of the most common things is patients are like, why can't you tell them what to do? And it would be great if we could, like, that would be fantastic. But we don't make those financial decisions on the insurance coverage part. And so it's just a huge frustration on all ends. And patients are frustrated. I think, a lot of times patients don't understand that we share in that frustration because, especially in the world of GLP-1s, these medicines are fantastic for what they do. We could make such an impact on so many lives if we were just able to get these meds in people's hands. And unfortunately, insurance is a huge holdup there in the cost of the medications.
Yeah, it's kind of like, why are they the ones practicing medicine? Aren't we supposed to be the ones practicing medicine? We try to give them a try, and it's like, nope. The other thing is that it's somewhat, there's a strong bias there. It's almost stigmatizing. Well, have they done behavioral therapy for X amount of months? It's like, how about X amount of years?
They've been or their whole lives, right?
They tried 10 years. Oh, do you have receipts to show? It's like, are you kidding me?
Right.
It's almost, it's actually ridiculous. And so, I mean, unfortunately, there is abuse out there. There are people that shouldn't be taking these medicines. These medicines specifically they're just so powerful. We've never seen anything like this. Phentermine, there's some abuse out there. If people have listened to this podcast, we've gone over what phentermine is. It's generic now. It's been out since the 1950s. Works pretty well, but has some side effects because it has a little bit of an upper type of mechanism. So it's cheap, pretty cheap, but it is controlled. So there is some control there. You can't really do it online. You got to see somebody in person first. The DEA is kind of overseeing this. GLP-1s, though, better side effect profile. They work much better.
Yeah.
And so people are using it for vanity weight loss. So then they're expensive. And for that, so insurances are basically like, all right, we got to put some sort of, they don't want to pay for this. Employers don't want to pay for this. This is the big thing. Like people are, there's all sorts of reports I see coming through about these employers basically saying they saw their costs for insurances just jump. I don't
Skyrocket.
know, hundreds of thousands, millions of dollars because of
Yeah.
these drugs. And so I understand that they want to put like blockers on, but at the same time, it ends up really harming the patients that truly need it.
Right.
Really, kind of a system failure. I mean, we could probably do hours and hours of why our medical system is probably not. It could probably it could be better. I'll put it that way.
For sure.
So, what are some things? I guess like what are some things that you'd want to let patients know who are listening to this? You know, the doctors don't need to listen to this, but the patients who are like, I don't understand this process. And like, what are some things that could like alleviate? I know you got into it. Like, we don't have control. We're going to do the best we can.
Right.
Anything, any tips there to try to help patients like get through this?
I think a big part of it. So oftentimes, like in primary care world, and if you're going to your PCP to start a discussion about weight and medicine, um, which is a great place to start in a lot of world. But those a lot of primary care offices are so bogged down with so many things that they aren't super efficient at prior authorizations either, mainly because of the manpower it takes and the time that it takes. Sometimes you're on hold forever. You have to go into certain different websites and do the work. And so I've had some patients in the sequence platform and members that say, my primary care doctor just said I won't do it if it needs a prior auth. And that's hard for a patient because they have zero control over that and they're seeking access to care to better their health. And it's I get it from a PCP perspective as far as it's just time consuming and there's so many other tasks to be done, but it's just that's a huge barrier. And so, just for patients to know it's sequence and we have a whole team dedicated strictly to the prior auth process. And that's amazing because they are well versed in what needs to be said. And if a med can get approved, they're gonna get it approved. That being said, there are some insurances that are just a hard stop. Like it's not even open for discussion. They won't even go through the prior auth process. And so patients, think, well, just do the paperwork and I can get the medicine, but some won't even let you get to that point. And it's just a hard stop, like, plan exclusion, we won't do it. And patients often come back and like, can you write a letter? Can you do this? And sure, we can do all of those things. Unfortunately, it's just not going to make a difference. And then the other thing is, patients will be like, well, I called my insurance and they'll cover XYZ. If they don't cover the weight loss medications, Wegovy or Saxenda, they'll cover Ozempic. Well, what they don't know is, oh, we'll cover it, but you have to have a type 2 diabetes diagnosis. And so they come back saying, but they'll cover this medicine. Why can it not get approved? And people on the phone that they're talking to, either don't know to tell them that, or, maybe they're not clinical, obviously, and don't have that information in front of them. But that's a huge thing is patients will have this hope that this medication is covered and then they're not diabetic, which is great. We would love to prevent these patients from
Right.
being diabetic, but then they just say, you have to have that type 2 diabetes diagnosis. I mean, I've had in my clinical practice where I'm like sending the insurance company has requested data from medical review journals showing that these drugs are,
Mm-hmm.
impactful for weight loss. And I mean, who has time in the primary care world to do that? But I'm sitting there sending these journal articles to try to get these meds approved. And it's crazy that the hoops you have to jump through to try to get them. But sometimes it's just no matter what we do, it's frustrating and they won't pay for it. So
Yeah, I think it's a good point because patients will be like, well, you need to do an appeal. I will try to do peer to peers. I've tried it for, let's say, Manjaro specifically. Everybody wants Manjaro, most powerful med out there, tirzepatide. By the time you're reading this, it might be approved for obesity, weight management. Ooh, I don't know. But I'll say at the time of this recording, it's only for type 2 diabetes at the moment. And these insurances have cracked down so far to where they won't even get on the phone with me. They will ask, they'll have a step where I'm like, hey, do you know who I am? Have you seen my Instagram? They don't care. They don't actually care about that. They, and I'll say like, no, but this person's very high risk,
Right.
XYZ. And they'll be like, but do they have type 2 diabetes? And I'm like, no, but, and it's basically, they will almost hang up on me. I'm
That's
not
right.
kidding you. There are, I can't name names. I don't want to get sued. I don't want our program to get sued, but there are programs out there. I'm pretty sure they're fabricating. There's fabrication. There are doctors out there who will fabricate what's on their prior authorization. Not a good idea for multiple reasons. Number one, obviously the clinician could get audited and they could get in trouble for fraud. That's their issue.
Right.
But if you were to fabricate and say that you have type 2 diabetes, that goes on your record. I don't think people want to have that on the record. Insurance premiums start going up. And so, not a good solution. So, and I know this whole nother conversation. This can drive people to going towards maybe not so safe compounded versions. Would not recommend that either. What we're just trying to do on this is lament, like basically say, yeah, we're frustrated too. Like this, it's really unfortunate. If the drug were $100 like it is in other countries, who cares? Just buy it cash. Well,
Right.
who cares? Just bypass insurance. Just get it for 100, $200, whatever. Not everybody could afford that, but many more people would shell it out.
Yeah.
And we do our best. Like when we'll say that, yeah, they have hyperlipidemia, hypertension, pre-diabetes, metabolic syndrome, and yeah, we'll try to get the ones that aren't approved for obesity, that are only approved for type 2 diabetes, but it's very few and far between. They're cracking down, and it's because of the demand. They can't even keep up with us. That's the cost and the demand. Lots of different things in the system that we just don't have control. There's lots of lobbying going on to try to be like, hey, we need to get rid of this middleman, the PBMs that are doing all those negotiations. It's a whole thing. It's extremely frustrating. So
Okay.
trust us, we want to get you these medicines. But and then yeah, like you said, your employer is the one who decides whether they have an obesity rider on their insurance. If you don't, you have a plan exclusion because of the stigma or bias that employer has, where they just simply don't want to pay, which maybe an underlying bias, or they just didn't even realize it, which does happen, by the way. So we give our patients letters to bring to their HR department to go like, hey, advocate for yourself, advocate for those with obesity, and cover these medicines. Sometimes that works, sometimes it doesn't. But if they don't have that obesity, if they have a plan exclusion, you can't pass go. No collecting $200.
Right.
I, I think it's going to get better. There's going to be competition here. So this is all about insurance, but okay, there are two big players in the game right now. There's Novo Nordisk, who kind of has a monopoly at the moment. Um, and Novo, don't sue me. It's a basically you're the only one with GLP-1 approved for obesity. Eli Lilly's jumping in. They're going to have tirzepatide will be approved unless something bizarre happens, but that will be approved very soon. But there are many other companies jumping in, developing these. So once we have more competition, again, don't expect it to happen in the next 1 to 2 years. I'm thinking 3, 4 years. I know that's frustrating, but I believe once there's more competition, liraglutide Saxenda will be going generic. That may help, although not as powerful as semaglutide or tirzepatide, but something that may be
Just a
uh,
hope.
something at least. So anyway, anything else? Sorry, I go off on rants on these things because it's just
No, I
ridiculous.
know it is. It's super frustrating. That's what I mean. I have this conversation literally every day of my life, which is fine, but it would be great if we didn't have to have this conversation and
Yeah,
just get the medication to people who need it. So the only other thing is, in tirzepatide and that getting approval for obesity and talking to patient off-label use and that sort of thing, I'll tell them like this will very soon be approved for weight loss. It should be very soon. I feel like I've been saying that for a while now, but
should be.
it should be. But it's still not going to be covered. So, like, patients will think, well, once it's approved, then my insurance will pay for it, and it's not the case. And so that is something I have to clarify with patients sometimes too. Is it's just gonna, it's gonna have an FDA approval, which is great, so we can use it on label at that point. But it still doesn't mean that insurance is going to cover the cost of it. So Yeah, it's a frustrating thing for sure. And as these medicines have become more popular, which I think it's great that patients have information and access and feel like there's hope for something that they dealt with their whole lives for a lot of people. And they come to us and like I saw this on TikTok or wherever, and it's great. But then I have to be like, well, these drugs are $1,000, and it's like, ooh, that wasn't on TikTok, and it's like, here's that conversation. And where I would love to get this medicine in your hands, we might have a little bit of work to do that. So,
Exactly. Well, thank you so much for coming on. Hopefully, if you're listening to this and you're like, oh, I understand the process now. It's not my doctor's fault or whatever. Send this to a
yeah,
friend, family member that has some frustrations. Understand that we're frustrated too. I promise. Like, I feel really bad when a patient can't get it who like truly needs it, and it's heartbreaking. So yeah, make sure you give us a review and whatever you're seeing this on YouTube or Spotify, Apple, whatever else. And thanks so much for coming on, Dr. Height.
it's been good.